Hi, good morning everyone. Today's my topic for presentation is rotator cuff syndrome overview and its interventions. As we all know, this topic is fairly broad and deep, but I would like to summarize into a few slides. So I will quickly topics under this following headings: anatomy, rotator cuff syndromes and impingement and different terminologies, prevalence of this problem in the community, pathophysiology of these problems, how does it like present clinically, and what we find during a clinical examination, what are the investigations, 11 investigations mainly, radiological investigations, and how do we manage a case. So as you can see on the slide, on the left hand side you can see a diagram showing the rotator cuff constitutes of supraspinatus, infraspinatus, subscapularis as well as the teres minor. On the right hand side you would see a grayscale image of ultrasound scan which is showing different soft tissues, then uh, the bursa. You can see the greater trochanter, supraspinatus tendon, deltoid muscle, and you can see the supraspinatus with its classical beak sign. So what is a rotator cuff syndrome? Rotator cuff syndrome encompasses a spectrum of diseases with a wide range of pathologies. It could be either started with an injury or could be a degenerative condition affecting the rotator cuff. Rotator cuff syndrome includes subacromial impingement syndrome. It could be a bursitis, it could be a tendinitis of the rotator cuff, or it could be a tear. The tear could be either a partial or a full thickness tear. Ultimately, in the long term, it will leads on to the development of a glenohumeral joint degenerative disease called as rotator cuff arthropathy. And as we mentioned, a rotator cuff could be as a tendinitis or a tendinosis. So it could be an acute or a chronic tendinopathy because it is due to secondary to repetitive eccentric forces with anatomical or mechanical risk factors predisposing to this particular condition. It could be an acute injury or chronic overuse resulting in a focally weakened cuff region. So the cuff region becomes focally weakened and due to repeated injuries, and these weakened regions evolve into or leads onto a partial thickness or a full thickness tear depending upon the type of the force applied on the upper limb. Another one is the shoulder impingement. This is a non-specific term often used to describe patients experiencing pains or presenting with symptoms with overhead activities. So it could be either an external impingement or an internal impingement. So what's an internal impingement? The internal impingement is found commonly in overhead throwing athletes, baseball pitchers and javelin throwers, or also could be seen in tennis players or even badminton players. Impingement at this, it is occurring at the posterolateral articular surface of the cuff. It is occurring during the maximum abduction and external rotation, which abates the posterior superior glenoid labrum and the rib. So it is called as a late cocking phase in throwing. It's also called as a thrower's shoulder. So it's an anatomical adaptive changes that occurs over the time in these athletes. Increased humeral retroversion and posterior capsular tightness. Another term used is glenohumeral internal rotation deficit, resulting from the anatomical adaptation which is mentioned above, that is the humeral increased retroversion and posterior capsular tightness, which is predisposed to throw his shoulder to internal impingement. So all these things has got a link, but they are not same. What is an external impingement? External impingement is synonymous with a subacromial impingement syndrome. External impingement, because of the external compressive sources like an acromion, leading to irritation, causes subacromial bursitis and bursal side injuries to the rotator cuff. So this picture you can see what is external impingement and internal impingement as a schematic representation of both the types of impingement. So coming back to the prevalence, in the literature, shoulder pain accounts for approximately 4.5 million office visits and about 3 billion healthcare costs in the United States alone. So you can imagine the magnanimity of this cost all over the world. So the prevalence of the rotator cuff syndrome in younger age group, less than 20 years, is around 5 to 10% of patients, and older age above 80 years, it is more than 60% of the patients. Altogether, the chronic shoulder pain accounts for around 67% of lifetime prevalence of pain in the adults, and of which the subacromial impingement is the most common cause of acute and chronic shoulder pain. No gender difference for incidence of rotator cuff syndrome as well as rotator cuff tears. Pathophysiology. So subacromial impingement, there is an extensive compressive theory. Inciting factors are anatomical or mechanical in nature, which leads on to increased pressure and pathological contact, leading to susceptible and tendinopathic cuff. So it's an extrinsic compressive theory. The extrinsic mechanisms include subacromial impingement syndrome and internal impingement. There is another theory called as an intrinsic theory. This predisposition of a weakened cuff that degenerates over a period of time due to aging, hand dominance, vascular changes, repetitive eccentric forces causing the cuff to weaken over a period of time, and finally producing dynamic instability of the shoulder. And ultimately what happens is that humeral head migrates proximally, which reduces that acromiohumeral interval, predisposing the cuff to further injury and compression and degeneration. So the intrinsic mechanisms are like tendon vascularity. As we know, there is a critical zones for the supraspinatus tendon, then tendon biology, tendon mechanical properties, tendon morphology, and genetic predisposition. How do they present clinically? It's normally presents with an insidious onset of pain, atraumatic, symptoms normally exacerbated by overhead activity. Most of the patients has got complaints of pain at the night, and they have got a history or a current history or a past history of sports participation, occupational history, and employment history of having repetitive movements or overhead activities, hand dominance, mainly predominantly seen on the dominant hand, history of injury or trauma to the shoulder or neck, or some kind of relevant surgical history in the past. So once we go through the history, then we need to go do a physical examination, right? So neck, we have to start with the proximal joint, that is the neck, to rule out the coexisting cervical radiculopathy. And there are special tests like Sperling's test and neurovascular examinations to find out nerve compression and vascular involvement. Then you proceed to the shoulder examination. Start with an active passive range of movement. Then look for the scapular disc kinesis and scapular winging. Then you have to go for the specific test for the rotator cuffs. And to start with, you start with a supraspinatus, the most common one. You have to do a Jobs test. There are so many named tests around the shoulder. I'm not going in detail for all these tests because sensitivity and specificity of this test is it's controversial as well as low. Then another test is a drop arm test. In this test, the shoulder is brought into a position 90 degrees of abduction in the scapular plane. Examiner supports the limb and then instructs the patient to slowly adduct or bring the arm to the side of the body. So a positive test means inability to maintain the abducted position, and inability to adduct the arm to the side of the trunk in a controlled manner. So slowly it drops. That's why it's called as a. Then you have to go for the infraspinatus. You can test the strength of the infraspinatus by keeping the shoulder by the side of the trunk and elbow flexed to 90 degree. Patient has to externally rotate the arm and examine resist the movement. Then there is another test called as external rotation lag sign. Keeping the shoulder in the same position, hold on to the wrist, then arm is brought to the maximum external rotation. And when you remove the force, the shoulder drifts into internal rotation. That is called as a positive test. When teres minor, for the strength testing of the teres minor, shoulder is kept at 90 degrees of abduction, elbow flexed at 90 degrees. So it is best isolated for strength testing in this position, while the external rotation is resisted by the examiner. There is another test called a sign called as a Hornblower sign. The shoulder is kept in 90 degrees of abduction and elbow is 90 degrees flexed. Then maximally externally rotated the shoulder under support. And the positive test means patient unable to hold this position and the arm drifts slowly into internal rotation from the external rotation when the examiner removes the force. For subscapularis, test called as an internal rotation lag sign. So the shoulder is behind the trunk about 20 degrees of extension, elbow flexed to 90 degrees. So examiner passively internally rotates the shoulder by lifting the dorso of the hand of the patient's back while supporting the elbow and the wrist. So a positive test means unable to maintain this position when the examiner removes his support. So the arm is not maintaining internal rotation and the dorso of the hand drifting towards the back of the patient. So this is called as an internal rotation lag sign. Then passive external rotation range of movement. Partial or complete tear of subscapularis can manifest as an increase in the passive external rotation compared to the opposite shoulder. Then there is a test called the lift off test and a belly press test. These are one for the lower subscapularis and the belly press test for the upper subscapularis. So lift off test more sensitive, specific for the lower subscapularis pathology. Positioning same as the internal rotation lag sign, which that is shoulder behind the trunk about 20 degrees of extension and elbow flexed to 90 degrees. Examiner places the patient's dorso of the hand against the lower back. So the internal rotation lag sign, like it was dorso of the hand of the patient's back. So here the test is like hand is kept against the lower back and then resist the patient's ability to lift the dorso of the hand away from the lower back. And the belly press test is arm is 90 degrees of elbow flexion and internal rotation. Testing is performed by the patient pressing the palm of his hand against the belly, bringing the elbow in front of the plane of the trunk. So one is behind the back and other is on the belly. So the positive test for the belly press test is elbow is not maintained in this position when the examiner is removing the support. So there are tests for the impingements. External impingement test is a near impingement sign and near impingement test. As we all know, the near impingement sign is positive when the shoulder is up, forward flexed beyond 90 degrees and the patient complains of pain. And the test is like impingement test positive means improvement is reported after subacromial injection of like a lidocaine, and a patient feels improvement in the pain. Hawkins test is passively positioning the shoulder and elbow in 90 degrees of flexion in front of the body, and when the examiner passively internally rotates the shoulder, the patient complains of pain. For internal impingement, patient is placed in a supine position and the shoulder is brought into terminal abduction and external rotation. A positive test produces a pain in the patient. As you can see in the figure, these are the top 4 tests are normally mentioned in the test books, and these are more sensitive and specific than the other kinds of tests mentioned for the shoulder. Then once you do the history and the clinical examining, obviously you need to confirm your diagnosis. You need to do some investigation. So start with a simple investigation like an X-ray shoulder, and patient positioning is important for this particular imaging. Patient is rotated between 30 and 40 degrees, offset the cassette in coronal plane. Rotator cuff arthropathy, you would see proximal humeral migration, decreased acromihumeral interval less than 7 millimeter. And you would find all kinds of degenerative changes, osteophytes in the acromion, proximal humerus, glenoid, in cases of advanced degenerative diseases. You could also see calcification of coracoacromial ligament or coracohumeral ligament, then cystic degeneration of the greater tuberosity, acromioclavicular joint arthritis also seen. Then X-ray you would see a hooked acromion. There are 3 types of acromion mentioned, right? Type 3 is the hooked acromion, best appreciated in the supraspinatus outlet view X-ray, and you could see ossification centers like os acromial, best seen on axillary lateral radiograph. Ultrasound scan is a handy tool. Many times it is underutilized. So you can decide upon the patient's problems of rotator cuff. Could be a tendinitis, peritendinous effusion of fluid in the bicipital tendon, even though it's not part of rotator cuff. You could see most of the supraspinatus tendon. You could see subdeltoid bursa, subcoracoid subdeltoid bursa. You could see the tendon pathology of supraspinatus, its attachment side, irregularities, as well as partial thickness or full thickness tear. You could see a calcification if there is in the supraspinatus tendon. Subscapularis you could see with external rotation of the shoulder. Infraspinatus you could see, and also teres minor. So most of the rotator cuff muscles can be seen at least in the distal aspect with the proper positioning of the ultrasound scan. In a meta-analysis of over 6,000 shoulders, it's found out the sensitivity of 9.96 and specificity of 0.93 in assessing shoulders for partial and full thickness cuff tear. So it's a handy tool, and also it has got pretty sensitivity and specificity regarding the rotator cuff tear. If you want to have a detailed evaluation, definitely you need to go in for a more sensitive investigation. It gives a more detailed evaluation. If you wanted to know whether it is a partial thickness tear or full thickness tear, and to know the extent and size of the tear, location, and if it is retracted, how much it is retracted. And in chronic rotator cuff tears, there will be naturally a fatty degeneration and extent of the fatty degeneration in T1 weighted images. Then better appreciation of subdeltoid and subacromial bursitis. Then you can see acromioclavicular joint, acromion morphology, and long head of the biceps tendon integrity. All detailed evaluations are seen in the MRI. So now, how do we manage? Here I am just following American Academy of Orthopedic Surgeons clinical practice guidelines. They categorize into 3 groups. The group 1 is partial thickness tears or full thickness rotator cuff tears, asymptomatic patients. So they recommend like symptomatic management via non-operative modalities. So mainly like physiotherapy and then other kinds of non-operative modalities. When it comes to group 2, it's a partial thickness tears but symptomatic patients. Patients with symptoms of external impingement or impingement syndromes in the absence of full thickness tears, they're first to manage with non-operative management. Now it can be tried for 3 to 18 months. And surgical intervention is individualized based on the patient symptoms, and then improvement in non-operative modalities and overall goals of the treatment. So here also, like surgery is not suggested as the first line of treatment. Even for the group 3 chronic rotator cuff tears symptomatic patients, this is weak recommendations because limited available evidence in the literature, and they compared with the rotator cuff repair and non-operative treatment. They could not find a strong recommendation evidence to say that which one is superior than the other one. So, what are the non-operative rotator cuff syndrome treatment modalities? Physical therapy, obviously, we know the mainstay of the first line of the treatment. So, managed with the partial thickness tears can be managed with physical therapy alone, with an aggressive rotator cuff and periscapular stabilizing strengthening program, as well as pain relieving modalities and range of movement exercises. Anti-inflammatory medication has got a role in the initial phases. First line of non-operative management includes use of NSAIDs along with the PT modalities. So this American Academy of Orthopedic Surgeons clinical practice guidelines says that there is inconclusive evidence for the use of NSAIDs, interferences, transcutaneous selective nerve stimulations in the presence of full thickness tears. But they have got a moderate recommendations for exercises and NSAIDs in the presence of rotator cuff symptoms in the absence of full thickness tears. So the evidence is not there for the full thickness tears. Corticosteroid injection, the most utilized injection in the subacromial space. Patients experiencing symptomatic relief almost instantaneously get a pain relief after the injection, and so that they can participate in the physiotherapy sessions, and they will be having a better outcome. Rest and activity modifications. Patients in the initial phases benefit from rest from because of the activity exacerbate the pain, especially those people who are in the occupation or sports participants. So they get a relief of pain due to a modified rest or activity modification. Prolotherapy is found to be, or PRP is prolotherapy or PRP is found to be better than corticosteroids. In a network meta-analysis, it showed that a prolotherapy significantly reduced pain compared with the placebo in the long term over 24 weeks. Whereas when they compared with the corticosteroid has got only short-term benefits. And the PRP is also significantly improved shoulder function compared with the placebo in the long term. So one is prolotherapy is significantly reduced pain in the long term, and PRP significantly improved shoulder function over the period of 24 weeks. So both are found to be effective treatment. Surgical management. There are different surgical techniques mentioned. It is beyond the scope of this particular lecture, but I will just rush through some of these commonly practiced surgical approaches. Subacromial decompression is a debris of the subacromial space. It is beneficial in patients that have persistent symptoms of external impingement or impingement syndromes after at least 6 months of failed non-operative modalities. So that's also not coming as a first line of management. Coracoacromial ligament debris is recommended in cases with substantial coracoacromial ligament fraying or calcification. In a meta-analysis of 9 studies comparing open versus arthroscopic studies, they found out equivalent surgical times, outcomes, and complication rates at an 1 year follow-up. But they found that the arthroscopic cohort returned to work quicker compared to the open surgery cohort. So there is an edge for arthroscopic surgical decompression of subacromial space. There is another procedure called as acromioplasty, shaving of the undersurface of the acromion, giving additional space to create a distance between the acromion and the cuff. Then os acromial, if there is a persistent symptoms, that's two-stage procedure is being done. First, the os acromial is fused using the bone grafting technique, because it is a kind of ossifications that are not fused, right? Followed by a formal acromioplasty after healing is achieved. Post-operative rehabilitation care is extremely important. After subacromial decompression or acromioplasty without rotator cuff repair, patients are kept in a sling for 1 to 2 weeks with early passive range of motion rehabilitation parameters. Initially instructed to avoid heavy lifting and exercises to facilitate soft tissue healing. The cryotherapy is applied for 10 to 14 days postoperatively, and physical therapy is often started postoperatively once the sling is discontinued. Full active range of movement should be achieved by 3 to 6 weeks maximum. And those people who are participating in the sports, they can go back to the sports specific skills around 6 to 8 weeks as tolerated. There are differential diagnosis of a lot of conditions comes into the mind when you look for impingement or impingement syndromes. Patient presents with pain and limitation of movement. So you could have an adhesive capsulitis happening there. It could be a rotator cuff tear, acromioclavicular joint arthritis, acromioclavicular joint sprain, trapezius muscle spasm, biceps tendinitis, biceps tendon rupture, calcific tendinitis, glenohumeral arthritis, distal clavicle osteolysis, cervical radiculopathy, and thoracic outlet syndrome, to name a few. As you can see in the image, this is an image of an ultrasound guided injection for barbotage of calcification of supraspinatus tendon. You can see in the first one there is one needle and two needles. One needle is for injecting saline, and another one is for draining. Along with that, barbotage is being done. Found to be an effective procedure for calcific supraspinatus tendinitis. These are my references, and for your patient listening. Thank you.